Okay, today we're going to talk about schizophrenia. This is a psychiatric disorder characterized by thought disturbances, altered affect, withdrawal from reality, regressive behavior, difficulty with communication, and impaired interpersonal relationships, as well as they have an impaired ability to perceive reality. I do not expect for you to memorize the DSM-5 criteria, but I do want you to just kind of skim through it and know that to really be diagnosed with schizophrenia, we do expect to see 2 or more of the following, and it needs to be for a significant portion of time during a 1-month period. So it's not just a one-time, clients present with this. It's kind of an ongoing, significant portion during that month period. And, we want to make sure that it's not caused by any type of medication or substance. Some of our key symptoms of schizophrenia will have what's called positive symptoms. This is where we have delusions or hallucinations. We'll see disorganized speech patterns, and I'll talk about some of those here in just a minute. They may have disorganized behavior, and then what's called negative symptoms. These are like movement disorders, a flat affect, anhedonia. This is a lack of pleasure, inability to begin or sustain planned activities. They may also have some cognitive symptoms. This is difficulty understanding information, trouble paying attention, and inability to use information after learning it. One of the other things that you'll see with schizophrenia is what's called catatonia. Catatonia occurs across several different categories of disorders, and this is one that we'll see it in, as well as depressive disorders, bipolar, any of our psychotic disorders. Catatonia is where you have stupor, a decreased reaction to the environment, or mutism. They may have rigidity, that's maintenance of a posture against the efforts to be moved. Posturing with waxy flexibility, negativism, resistance to instructions, or excitement. They may be severely agitated, out of control, and have a potential for violence to self or others during these periods of stupor or excitement. These are some things that I just wanted to make sure you understand. Comorbidity are things that you'll see that go we'll find alongside. So we may see that our schizophrenia patients also have some substance use disorders, anxiety, depression, risk of suicide. There may be some physical illnesses that we see, risk of premature death, and polydipsia, where they have excessive drinking. So these are just things to look for when you have a patient with schizophrenia. Let's talk a little bit about the phases. So in the prodromal phase, these are mild changes in thinking, reality testing, and mood. It's insufficient to really meet those diagnostic criteria for schizophrenia. But we do start seeing these symptoms. They appear to be, in a month or more before they really have the first full-blown episode. So you start just kind of seeing them, sporadic episodes. Sorry. And then you see like this acute or pre-psychotic phase. This is later symptoms vary. You may see a few symptoms that are mild to many disabling symptoms, characterized by like hallucinations, delusions, apathy, social withdrawal. After the pre-psychotic and acute phase, you get to more the stabilization or residual phase. And this is where we start seeing that the symptoms start diminishing. There is our clients start moving back toward that previous level of functioning, and then they get in this remission, or we'll call it the maintenance or residual phase, and we have a stabilization in the condition, and we have a new baseline of what normal behavior is. When I talked about some of the speech or the symptoms of schizophrenia, I mentioned different types of speech disturbances. So clang associations are when they'll start stringing together words that sound alike. Duck, truck, puck. Concrete thinking, we see this sometimes with children, so they're not able to have that abstract thought. Everything's very black and white. Echolalia is when they'll repeat the words of others. So you'll be trying to interview them, assessment, and they're just repeating your words right back to you. Flight of ideas are when they cannot stay on topic. So you may be trying to talk about, maybe they acted out in group therapy and you're trying to have a discussion about that. And they are immediately not able to stay on track with that, but they're talking about a time when their truck broke down. And so they have an inability to really stay on topic, and they just can have a very rapid change of topic. Ideas or reference are constantly trying to bring things back to where they have personal meaning. Loose association is when they'll try to tie together unrelated events to another. We mentioned mutism. That's when they have a refusal to talk. They'll make words up. Neologism. So invention of words. And then we can have repetition of phrases, pressured speech. So that's where they'll talk very fast and rapid. And sometimes if I'm trying to rush either in class or when making these videos, I'll end up with some pressured speech. And then we have word salad, where it's just very random, jumbled words that make no logical sense or connection. Some other things that we may not have touched on that I want you to make sure and assess is always be, assessing kind of their flow of thoughts. Are they having any, blocking, which is a gap or interruption of speech due to absent thoughts, that concrete thinking that we mentioned before. Assess for any disturbances in perception. So these would be hallucinations or false sensory perception. So they can have auditory or visual hallucinations. So they're seeing and hearing things that are not there. Illusions are misinterpretation of external environment. Depersonalization, this is when they perceive their self as alienated or detached from their real body. Delusions, and this is when there's false fixed beliefs that we cannot change by reason. We mentioned that their affect, this is their feelings or mood, may be blunted or flat or just inappropriate for the situation. So they have an incongruent affect related to the context of the situation. Watch their behavior. It may be incoherent or disorganized. They may be very impulsive and uninhibitive. That we can see some social withdrawal, changes in their personal hygiene. And then check their interpersonal relationships, because they often have problems establishing trust, difficulty with intimacy, and they may have some fear toward others. So some of the interventions, we need to work really hard on establishing trust, sit with our mute patients, provide a safe and secure environment. We may need to assist with their physical hygiene and ADLs, use very matter-of-fact, non-judgmental approach, very clear, simple, concrete terms when talking with the client. Accept and support their feelings. Use clarification. Reinforce congruent thinking. Always be stressing reality. Try to avoid arguing and avoid agreeing with inaccurate communications. Set limits on behavior. Avoid stressful situation. Try to structure time for activities so as to limit time for withdrawal. Encourage them to identify positive characteristics related to self, and praise when they have socially acceptable behavior. Try to avoid fostering a dependent relationship. They can sometimes be dependent on their care providers, and really promote family involvement in therapy, teaching, as well as medication compliance. There are 4 A's that you can use to try to remember the important characteristics of schizophrenia. The first A is autism. Loss of connection with reality. Their thoughts are odd and internally stimulated. The second A is affect. It can be flat or blunted, so lack of emotional expression. The third A is association. So they may develop those loose association, rapidly changing from one subject to an unrelated subject. And then the fourth A is ambivalence. So they may simultaneously hold 2 different attitudes about a situation. And so some of our medications that we will use, this is where you'll see the antipsychotic medications used. We have first, second, and third generation antipsychotics. We have some injectable antipsychotics that are both short and long acting. So our first generation antipsychotics are the dopamine antagonists. They target the positive symptoms of schizophrenia. Because they've been around longer, they're less expensive than the second generation medications. But some of the disadvantage to this is that we see more extrapyramidal side effects. We also see some ACH, anticholinergic side effects. They can develop tardive dyskinesia and weight gain, sexual dysfunction, and some endocrine disturbances. The second generation antipsychotics treat both the positives and negatives. Big advantage is there is minimal to no extrapyramidal side effects, so that is a big positive. The disadvantage is that there is typically significant weight gain and risk of metabolic syndrome with our second generation antipsychotics. And then we've got our third generation antipsychotics. Some people will call these our atypical antipsychotics. Aripiprazole is an example, Abilify. These typically will treat positive and negative symptoms of schizophrenia. And again, they don't have as much risk of the extrapyramidal side effects. We sometimes will see these used when they've not responded well to our typical antipsychotics, or if they've had significant side effects. And especially because we have little risk of the extrapyramidal side effects or tardive dyskinesia. And then this goes into some of the dangerous responses that sometimes we can see with our antipsychotics. Because of, the agranulocytosis, we'll typically do lab work where we're looking at, their blood counts for them. We want to assess for neuroleptic malignant syndrome. I don't think we've really talked about NMS before, but with this, it's life-threatening. And typically what you'll see is high fever, sweating, unstable blood pressure. So we want to identify, treat, and this is one where we'll have to change, medications. Look for any QT interval is, those dysrhythmias. So we want to be looking for any monitoring pulse, looking for any irregularity, and then we'll look at our liver enzyme levels. And this is we mentioned this, the extrapyramidal side effects when we talked about our, antipsychotic meds on our handout. The Parkinsonism is the shakes or tremors that you can see, shuffling gait, rigidity. Some of these will start typically within 1 to 4 to 6 weeks is where we'll start seeing this. Dystonia is some of those jerky movements, uncoordinated jerky movements. We mentioned neuroleptic malignant syndrome, tardive dyskinesia. This is a late in treatment. So dystonia happens acutely. Tardive dyskinesia happens after they've been on medication for a while. And so that's where they may stick their tongue out, smack, blinking of their eyes, and they can end up, if we don't catch this, this can be permanent disability. So your nursing responsibilities, look up your drugs before you give them, know the side effects, monitor the response to it, and then give good client and family education.